Thank you, everyone, and good afternoon, everyone. I am, as Nick said, Tine Hansen Turton, President and CEO of Wood System of Care, and also co-founder of the Social Innovations Journal, with Nick Torres. And it's really been a wonderful journey for many years to highlight all of the regions and actually national and now globally innovations. So much wonderful things go on, and if we don't share it, nobody knows about it. And that's one of the purposes of the journal. But we are delighted here at Woods to host today's panel in celebration of the December 2025 edition of the journal, which we also proudly sponsored. And I hope you'll take the time to read the 23 wonderful articles. And I think that you'll get introduced to some of the writers a little later on in this program. So a little bit about Wood System of Care. We are a population health management organization serving more than 40,000 individuals through 14 wonderful affiliates and many partners across Pennsylvania and New Jersey. And our system of care was established to create seamless integrated access to health and human services, what we all call within the system the no wrong door approach. With the idea of reducing fragmentation, expanding access, and improving outcomes across the lifespan, and also making care delivery and services easier for the people we serve and their families. This commitment to integration, innovation, and collaboration is why we continue to sponsor the Social Innovations Journal each year, and why I think today's discussion is so meaningful to us at Woods. In September, we had the honor to work with our Molly Woods Hair Global Center and the Network Towards Unity for Health, or TUF, where we convened the Intellectual and Development Disability and Autism Summit at our headquarters here in Langhorne, Pennsylvania. And the summit excitedly brought together more than 450 participants from 29 countries to share research, lived experience, policy strategies, program strategies, all aimed at advancing integrated person-centered systems of care for neurodiverse individuals. And now, building on that momentum, this issue of the journal, which is titled Innovations and Models of Care in Health and Human Services, Advancing Care Systems and Policy for Complex Needs, features an article by Anapriya Misra highlighting key insights from the summit. And as many of you know, individuals with intellectual disabilities, development disabilities, autism, behavioral healthcare needs, and other complex conditions continue to face significant barriers to care. And these challenges are compounded by provider shortages, fragmented systems, and also the social determinants of health. So this edition explores 4 core areas: policy and systems transformation, supportive and affordable housing, therapeutic and technological innovation, and workforce, family, and community engagement. Several articles speak directly to these priorities, including Nicole Powasnik's work on trauma-informed high reliability in patient psychiatric care, Lynn Unipan's article on AI-driven decision support in residential behavioral health, and housing innovations highlighted by Connor Rockhill and Nancy Bastian's article, where they talk about demonstrating how mission-driven and workforce housing can improve population health outcomes. The issue also features therapeutic and clinical innovations, such as Stephanie Ferrer's article on music therapy for adults with intellectual disabilities, and Dr. Henshaw's collaboration with Woods to advance dental education for individuals with autism and intellectual disability. Family and community engagements highlighted in Nina Wall's Voices That Change the System, and Jordan Hollander's Building a Coaching Culture which translate values into everyday practice. That was just a snippet of the many articles. Again, they're wonderful, and I really hope you take advantage of reading them all. And together, these 23 articles showcase practical solutions, focused approaches to advancing care, equity, and the opportunity for individuals with complex needs. With that, I am now very excited to introduce our panel today. Our panel reflects many of these themes and have vast experiences in those fields. And we'll, of course, be monitoring the chat. So if you have questions along the way, please just submit questions, and we will field them in the Q&A session, and we'll leave some time for that as well, so all of you can engage with our presenters. And with that, I'm going to actually invite our panelists to briefly introduce themselves, and then we'll get started. So John, I'm going to start with you.
Good afternoon, everybody. I am John Rubin. I am the CEO at Pendel Mental Health Center in Langhorne, Pennsylvania, a community-based behavioral health center. In previous lives, I've served as the Director of Housing and Human Services in Bucks County, Pennsylvania, and also as a Deputy Secretary for Children, Youth, and Families for the state of Pennsylvania under Governor Wolf, and appreciate having gone into government and now being able to be back serving the community. It's my pleasure to do the work and also appreciate being asked to be part of this panel. And I look forward to the discussion. Thank you.
Great to see you, John. Nicole?
Good afternoon, everyone. My name is Nicole Powaznik. I'm the Chief Nursing Officer here at the RWJ Barnabas Behavioral Health Center in Toms River, New Jersey. And I'm also the Vice President of Clinical Operations for the Behavioral Health Service Line. We have over 500 inpatient beds, a wealth of outpatient services, and multiple PES and crisis units. So thank you again for having me.
Thanks for being here, Nicole. And Nancy?
Good afternoon, everyone, and happy holidays. My name is Nancy Schneelak. I'm Vice President of Supported Housing, Homeless Outreach, and Justice Involved Services. I work for Bridgeway Behavioral Health Services, where we're providing intensive support to individuals with serious persistent mental illness within Central Jersey. I've been with Bridgeway for 36 years now. I started off as direct service worker in our homeless outreach program and has continued the journey with our supported housing teams.
Great, thank you. And Pokey?
Hello, everyone. Happy holidays. It's a pleasure to be here with all of you. Thank you to Teen and your team for putting this together. My name is Dr. Pokey Balash, and I'm currently a Health and Aging Policy Fellow and an American Political Science Association Congressional Fellow, currently working in the office of U.S. Senator Andy Kim. My background spans clinical care as a nurse practitioner in geriatrics, executive leadership in long-term care and disability services, as well as state and federal policy. Prior to my fellowship, I worked extensively in care delivery and systems leadership with a focus on integrating health and human services for populations with complex needs. I also bring my lived experience as a family caregiver, which has deeply shaped how I think about systems, equity, and what actually works for families. Thank you.
Thanks for being here and all your support. Last but not least, Christine, my colleague Christine.
Good afternoon, everyone. My name is Dr. Christine Williams Walker. I'm currently the Director of Behavioral Services here at Allies, a role that I have been in for the past 5 years. I am dedicated to this position and to this not only organization, but to this field of individuals with intellectual disabilities. I oversee the behavior specialists, as well as we have 2 BCBAs and RBTs here at Allies.
Great. All right, let me start then with some questions for the panelists. John, your experience has sort of spanned. I've known you now in different worlds, and I travel in different worlds too, so it's fun when we can do that. But your experience has spanned into human services, child welfare, housing, intellectual disability, and behavioral health sectors, including, I think, a stint leading systems redesign efforts with a human services system nationally, consulting, and now you're CEO of Pendel Mental Health Center. And you touched a little bit on it. Could you speak to, I think, all the various roles, but also, one particular topic in your article on the ROSE overdose prevention program?
Yep. Thanks, Teen. And I'll speak really specifically about the ROSE program. It sounds like we'll have a lot of discussion. I appreciate that even this panel is pulled together around the innovations and model of care and integration of services and really the behavioral health and housing and all these different pieces come together to serve the people that we're serving in our community. I will share, as I came to Pendel Mental Health Center as a nonprofit in the community, one of the things I was really interested in doing is how do we connect ourselves to the community. We don't want to be an agency that's classically just responsive to people walking in the door or to the government funding silos and restricted. And how do we ourselves put ourselves out and get to know the people in the community and to have the people in the community know who we are, while also really serving the community. And the ROSE program, ROSE, for anybody who hasn't seen the article, stands for Restaurant Outreach Support and Education. because I think it's been fairly well known that drug use is fairly prevalent and opioid use has been prevalent throughout the restaurant industry. And we've seen a lot of overdoses, not just in restaurants, but really amongst the staff. So we focused on that trade in going out to restaurants, and we really just go out blindly. We knock on the door, and we, in collaboration with our local Bucks County Drug and Alcohol County Authority, Drug and Alcohol Services, have put kits together that provide Narcan, fentanyl test strips, local resources, and we knock on doors and we say to the restaurants, we would like to help potentially save lives. We want to educate your staff on what to look for, how you might potentially spot an overdose, how you might help your staff talk about it and feel like a recovery-oriented restaurant where people would want to come to work and feel safe, or potentially, again, save the life of a customer. And so we've been out in the community knocking on restaurant doors and offering this service free to the restaurant. And we offer and we'll do the training. We'll do it in a few minutes. We'll do it if they only want to give us 3 staff to meet, because we know the restaurant and they can't pull everybody off the floor and have us train everybody at once. Otherwise, you would never get your food, right? So we can do a couple of people at a time. One restaurant even said, "Can you come back on a Saturday morning? We have a full staff meeting," and we trained 25 staff at an empty restaurant on a Saturday morning. So it really is, how do we go out into the community? How do we meet with the restaurant and offer really ourselves as an agency that wants to help the community and be more woven into the community, and also, frankly, moving ourselves from just we are treatment and recovery to also how do we do more prevention services in the community and outreach, ultimately, hopefully lower the stigma around conversations. Often we start our presentations with, has anybody ever witnessed an overdose? Has anybody, and staff are raising their hands and they're nodding. And we want to destigmatize some of these conversations and have people have the resources that they need in their community. And so, again, appreciating this conversation as not being like one siloed element of human services, but how do the human services pieces come together, and the public-private partnerships, how does government and how does community and how do private agencies all sort of work together to support the community. And so that's really a big part of the impetus for the ROSE program. I will say we didn't invent it. I had heard of this similar program, again, if you read the article, in Delaware called the Restaurant Accolade Program. But like most programs, they're not just plug and play. You can't take what somebody else did somewhere else and do it here. You have to build it around your community and your resources. And we've been able to do that here in Bucks County, Pennsylvania. And we've been able to get it off the ground and running now. And it's early days for us. But again, we've seen the restaurants really interested and the staff really interested in getting the information. So we appreciated the opportunity to share about the program in the journal, and also to be able to share it with you today.
And I think, just thinking about your role, because you know everybody here, you know all elements, the private sector, the community, government, how lucky, having you back to bring a program like that, because you're unique, because you've been here for, you've been here, but you've been away, but now you're back and really being able to put it all together. I might come back a little bit later on to sort of talk about, sort of your various roles, because you've done it all. And I think that's kind of interesting in the health and human services sector. Maybe come back. So keep that in mind.
I appreciate that. And I'll even say I started as a caseworker. Right. I started, my degrees are in social work. And so it's I feel that I've seen the front line as well as the administration. So happy to talk about that. I know so thanks. We'll turn it over back to you.
Sounds good. Well, Nicole, you contributed an article to this edition that focuses on transforming inpatient psychiatric care through a trauma-informed approach called the RICH framework. Tell us a little bit about that, and also how that impacted sort of both the patient staff and also the hospital and the health system.
Absolutely. Thanks so much, team. The Barnabas Health Behavioral Health Center is a 100-bed freestanding acute care psychiatric hospital here in Toms River. And we care for adults 18 and older. Some are voluntary for treatment, and some are involuntary for treatment and require a court order. Across our 3 units, we have a short-term care unit that takes care of serious chronic mental illness, a voluntary unit, and a mixed unit that cares for older adults. I've had patients as old as 102. And we see patients with diagnoses such as schizophrenia, bipolar disorder, depression. Many have co-occurring substance use disorder, dementia with behavioral disturbances. And what we've noticed is that many of them have trauma. And trauma results from an event or a series of events that an individual has across their lifetime that physically or emotionally is harmful, and it can have really long-term, far-reaching adverse effects on their well-being. And we recognize that mental health and trauma are deeply, deeply entwined. And so in 21, we embarked on becoming a trauma-informed organization. And we drew upon our work as a high reliability organization, which helps us reduce preventable physical harm, and developed a framework, the RICH framework, with a partner to shift our paradigm from one of control to more collaboration. And, the impact has been, nothing short of amazing. We believe that people are more than just their diagnoses, that they themselves wish for a different way. And it's our mission to assist them and help them in any way that we can. Reducing the risk of re-traumatizing a patient by leaning into our trainings and building psychological safety for our patients and our team. We seek to not invalidate someone's feelings or to use judgmental language, right? We don't call someone the borderline. It's understanding that people have a certain behavior, and while it appears maladaptive, it's one that they've learned to have a need met. We've built relationships based on mutual respect, give choice where we can, modify policies that were very archaic and more my way or the highway, and focused on control when appropriate. We help patients, recognize their triggers and give them help on how to stay in control. And we've seen a huge improvement in our patient experience surveys, particularly around perception of courtesy and respect. We have reduced manual restraint application by 35% across our facility, and that includes the short-term care unit, where many of our patients have serious mental illness. We've reduced workplace violence events by 28%, and that includes injury, which I think is very important. The training has benefited our team by enhancing their resilience. And we've had a positive result in our employee engagement survey, where they're saying things like they felt heard, supported, valued, their words. And so, by fostering this culture of safety, trust, and empowerment, trauma-informed care can serve as a microcosm for this broader, more compassionate societal change that we really need to support healing. There is no downside to giving this training and to being empathetic, kind, caring, and compassionate to our patients.
Love it. And Nicole, before we go on, can you talk a little bit about, not everybody knows the Toms River community and I think John brought up the importance of, we have to adapt to the communities we're in. So we happen to be in the same community with John. So I certainly know more about that, but maybe a little bit about Toms River, because I think it's a unique area.
Yeah, absolutely. So Toms River is in Ocean County and has its fair share of folks that identify as having mental illness, lots of substance use disorder, and very limited resources in our community. Folks that are unhoused have nowhere to go. There are no homeless shelters. There is minimal infrastructure for behavioral health, particularly if you don't have insurance. And there is no appetite really to assist these folks. There is a stigma around mental illness in our area that we work very hard with our local leaders to combat.
No, and I think that stigma,
and that's true, Caitlin. I see lots of veterans. That's correct. That's correct. And the VA, has its own challenges that we work through.
Yeah. And again, so that makes that kind of program you're doing extra strong, hard to do. So yeah, really, really a wonderful approach. All right, Nancy, talk a little bit about, so I'm going to go to you next. And so you've been in this area for a long, long time, although you look like you're still 20. What's your perspective on supportive housing, sort of the intersection between mental health, addiction, physical health, and justice sectors? And maybe talk a little bit about the work you do and have done, because you have such a wealth of knowledge and know a lot about, I think, a different community, and maybe introduce us to the community you're working in, and then how you see all this work together.
Sure.
And of course, by the article as well.
Sure. So Bridgeway is a behavioral health provider offering a wide range of services to individuals with serious and persistent mental health needs. Our service area is Central Jersey. The service that we have is a wide range from outpatient services, crisis intervention, psychiatric emergency services, as well as the CCBHC. However, many of our Bridgeway programs are community-based and focus on outreach. We believe that providing services in the individual's home and community environment really allows us to help develop that holistic approach and holistic services to individuals. These outreach services include PACT, which are assertive community treatment teams, our supported employment, supported education, which help people go back to work or school, our homeless outreach, which outreaches people right on the streets to try to get them off the streets and into places to live, our justice involved services, which really help people that have mental health disabilities, that got caught up in the criminal justice system to try to get linked up to community-based services, as well as ICMS, which is intensive case management services, and the program that's near and dear to my heart is supported housing services. So Bridgeway started actually providing permanent supported housing services back in 1997. This is when the whole movement of developing supported housing services kind of started. We started off having just 3 condo units for 6 homeless individuals. And today we have over 8 supported housing teams providing throughout Central Jersey, servicing more than 500 individuals and families in their own home. So Bridgeway has a scattered site approach, which allows individuals to use rental assistance vouchers and take them to the community of their choice and then find housing in that community. And then we wrap services around them in their apartment. So early on, we recognized that while Housing First model successfully helps individuals obtain housing, we really need to have, in order to have long-term success, we need to have a broader and more comprehensive supports for our individuals. So we also realized that our staff are very good at case management services, linking up to the different services and resources that they have and need in the community. But we wanted our service to be much more than that. We trained all our staff with motivational interviewing and cognitive behavioral techniques as the core counseling skills to have, whether you're a bachelor's level person, master's level support person, peer level support, nurse. We train everyone in those 2 core competencies to really help individuals. And some of the things that Nicole was talking about, the empathy, addressing trauma, really using the MI and these techniques to address those needs of our person served. We also have introduced evidence-based clinical interventions, doing assessments such as PHQ-9, GAD-7 assessments, to really looking at people's symptoms of depression and anxiety and how we can wrap services and supports around that individual to help reduce the pressures in those areas. And we also actually received special training from the Beck Institute in recovery-oriented cognitive therapy, which really helped us reach out to those individuals that were not engaging with our supportive housing counseling or supportive housing services, and really reaching out to them in different ways to try to engage them. And really, the CTR really helps people meet people where they're at, where they're willing to talk to us about, and what they're willing to engage with us about, and then start building relationships from there. So all of these approaches all reflect the dimensions of wellness, some of which will be discussed later in the presentation. And as a result of these integrated supports, our supported housing program has been able to maintain a 98% housing retention rate, which we believe is largely due to the comprehensive services we've been providing. So that's it.
Yeah. Thanks, Nancy. And just that we all good at using acronyms. So if you heard the word CCBHCs, for those of you who don't know it, it's Certified Community Behavioral Health Clinics. And we actually have 2 within our system, and Bridgeway, as Nancy mentioned, runs one of them. And that's an interesting model where it's integrating primary behavioral health care and also other social supports, and kind of modeled after the Federal Qualified Health Center program. So I'm just delighted. I got to put a plug in for them. I am on the board. I know the Beck family very well, on the Beck Institute of Cognitive Therapy, and the CTR program is like nothing else. And I think what you also demonstrate, Nancy, is that you guys are, you'll talk more about that later, but you're also, really executing evidence-based programs. And so there's evidence behind all you've done, and you guys have done it for many years. So thank you for that. All right, Pokey, you've worn numerous of hats in your career trajectory, a lot of them, not all policy focused, from service on the U.S. Senate Committee on Finance, focusing on Medicaid, Medicare, long-term care, and intellectual disability community, to clinical care, as you mentioned in your introduction, that you work as a health and aging policy fellow. So talk a little bit about your pathway from your work, I think also your personal experience you mentioned in Hawaii, to the work that you are doing now.
Thank you for that question. I would say I had an unconventional pathway. I didn't intend to end in policy or to even be involved in policy. But as you mentioned, Teen, really my pathway, my journey, my story really begins in Hawaii. Really, we're at the intersection of aging, disability, family caregiving. And as a family caregiver, I serve and have the privilege and honor of serving my father and nephew. But it didn't just stop there. It really was serving my community in a place where resources are limited, but community and culture are strong. And culture is really where I think this first began for me. In Native Hawaiian culture, as many cultures, values get instilled very early on, the way that we view elders, those who are in need. And it was my grandmother and my parents who really kind of guided me into this path of servant leadership. And always making sure to take care of our people. So my triad of experiences as a clinician in my leadership roles, policy, all underneath that, my through line is being a caregiver, not just in my community, but also within long-term care. And through those experiences, the different roles I've played, I became a user of the system in so many different ways and began to experience and see firsthand how fragmented our system really is, how challenging it can be, how it can be so wonderful, but how it can also fail people, especially vulnerable populations like the elders, individuals with disabilities, families, and those navigating complex needs without a roadmap. So as time went, I realized that many of the challenges we were facing, not just locally, but in many different places, workforce shortages, Medicaid constraints, lack of integration across health and human services, were driven by decisions made upstream, many in policy and financing. So that realization is what pushed me towards policy. I started out in advocacy work, and then it was just kind of like a natural transition. So I first began at the state level, nationally, and then globally, really looking at how do we create these macro level changes that will affect so many people, establish these relationships, and bring together systems. So as you mentioned, serving on the Senate Finance Committee gave me that exposure, a closer look at policy and financing. And then with Senator Andy Kim's office, I can kind of bring those together to the real world implications and how decisions affect people, not just on paper, but in homes, communities, and care settings. And all of that really ties together for me as a systems thinking, really grounded in the lived experience of how we design care models, payment structures, and policy. All of that actually is going to support people across a lifespan rather than to force them to navigate silos.
Sounds good. Well, thank you for what you're doing. I think the two areas of community, then you've got culture, and I know even Tom Sherman, I know that's cultural, I think also, we touch on that, when Nicole plays a role in our communities and sometimes multiple cultures. And I think we're going to return a little bit later to the systems thinking because of, what's coming at us in the broad health and human services sector. There is a need for a complete sort of, I wouldn't call it system overhaul, but rethinking of many of the things we've done for a long, long time. And we've changed as a population in the United States. All right, Christine, you have also had an exciting career trajectory that sent you through a journey. I've known you in two roles, in two agencies under the Wood System of Care, Wood Services and now Allies. So what inspired you to sort of dedicate that major portion of your career to supporting individuals with intellectual disability and development disability and neurodiverse challenges and autism?
Well, team, thank you so much for the invitation to be a part of this panel, being alongside these experienced colleagues. I truly consider this an honor. At the As a clinician, I'm a clinician at heart. And with a doctorate in clinical psychology, what drew me to this work early on was a chance to make a real positive difference in someone's life. My first position after finishing my training was at Woods, and this is where I gained invaluable experience working with individuals with complex needs, lessons that still guide my work today. One of my earliest and most meaningful experiences was with the young man who I'll call Patrick that I work with at Woods. Patrick displayed several physical aggressions towards his mother, and he displayed high levels of perseveration. His mother was unable to take him out into the community, not able to care for him in the home, unless someone was in the home. Over time, I developed a consistent schedule of engagement between Patrick and his mother with staff's involvement and support. We were able to help Patrick go out into the community with his mother and eventually have home visits. And then it led to overnight visits without family support. Um, while I was, while I was, while I was positive change, while I was seeing these positive changes in Patrick, um, I also learned some of my most important lessons from my greatest challenging individuals. I learned patience, consistency, and importance of clear expectations. Um, not everyone worked with, not everyone I worked with had family involvement, which in those cases, I quickly learned just how critical staff's relationships are with our individuals. I once worked in a home staffed primarily by men. And they were the most nurturing individuals I have ever encountered. They didn't just see themselves as caregivers, but as teachers, mentors, encouragers, and helpers. And one of them even thought that he was a professional body trainer, a bodybuilder. And he worked out with the individuals in the home. They thoroughly engaged the individuals. Their approach created a sense of safety, and safety is fundamental. Positive behaviors can only truly develop when people feel safe, supported, and feel supported enough to build relationships. With this foundation of strong, positive relationships in place, I was able to bring my clinical training to help staff understand what they were doing, they were doing well. I spent a lot of time teaching about diagnoses and why certain behaviors show up the way they did. Over and over, staff shared how meaningful it was to understand how the individual's history and diagnosis shape their current behaviors. That experience really sparked my passion for teaching and training, especially around supporting individuals with intellectual and developmental disabilities with co-occurring mental health needs. Today, I work at Allies Residential Services, where we support children and adults with intellectual and developmental disabilities, some of whom also have mental health diagnoses. We serve over 350 individuals. We are in 19 counties in New Jersey, and we have an employment program in the state of Delaware. We have 7-day programs throughout the state, which serves our individuals and individuals within the community. We have 16 medical homes with one more in the works, and it should be done by May 2026, hopefully. Our goal is to fully integrate the individuals we support into our communities and help them to live as independently and meaningful as possible. That means accessing community-based resources like medical providers, dentists, orthodontists, crisis services, and encouraging competitive employment for those who are able. Um, our Currently, I serve in a supervisory role at Allies, where I supervise a team of behavioral specialists who are primarily trained in applied behavioral analysis. During supervision, I intentionally integrate mental health considerations along with behavioral approaches. I also regularly train new hires, staff, and managers, and I consistently emphasize the importance of positive relationships, active engagement, and respectful support. Our agency also has a full-time and a part-time BCBA, I think, as I mentioned before, who also provides supervision and support to our behavior specialists and registered behavioral techs, who we call RBTs. The behavior specialists develop behavior support plans, and they are developed to decrease behavioral challenges, but also to increase skill acquisition. The behavior specialists train staff and support the work of the CSS. Our RBTs are stationed in the home, in our highly behavioral homes. They support the staff in maintaining the integrity of the behavioral plan. The RBT function as the liaison between staff and the behavior specialist. They also are basically role models for the behavior special before the CSS while the behavior specialist is not there. And again, to keep the integrity of the behavioral plan. They're taking data, they're ensuring that the staff are in the home creating following the plan, but also taking data so that the behavior specialist will be able to analyze the data and see if the plans are working. One of our biggest shifts clinically in our agency has been how closely our behavioral, nursing, and residential teams now work together, thanks to our leadership of our Vice President of Integrated Health Services, Dawn King. We have moved from working in silos to truly collaborating as a team, bringing behavioral specialists, nurse navigators, residential staff, support coordinators, and guardians together as a team. And it has totally been a game changer in us changing behaviors and creating support for our individuals. Everyone feels included, informed, and aligned in the treatment direction. And most importantly, our individuals benefit. At the heart of all I do, I simply have a commitment, and that is to understand the whole person and to create safe environments to grow and helping the individuals I work with to make meaningful connections. This commitment continues to guide my work every day. Thank you.
Thank you, Christine. And yes, you are absolutely a clinician at heart, and you started with heart, you ended heart. And I just saw Steve's comment, and there is absolutely a commitment from the Wood System of Care, and we have a global center to do education, and we see it look upon ourselves to say, if not us, who should be educating our providers. And also we have clinical relationships with hospitals, health systems, universities, et cetera, to really teach and train our doctors, nurses, social workers, you name it, in neurodiverse care. And we see that something, unfortunately, not yet is happening in the schools, but it will in the future, and something we all plan to be working even more on. So thank you for that comment. So let me go to Nancy. There are several articles in this edition focusing on various aspects of housing, workforce housing, affordable housing, partnerships needed for those to happen. And with example, your organization's project to help supportive housing residents with mental health and challenges and address diabetes and overall health and wellness. So tell us a little bit about the program and the results.
Sure. So within our supportive housing program, we are seeing trends that are closely mirroring the broader adult population, particularly as we serve a large, growing, aging cohort. Now, I'm not saying 50 years old is old. I'm just saying the average age of our supportive housing tenants is 50 years old. And that while this isn't old by today's standards, the national data is showing that individuals with chronic mental health conditions tend to die on an average of 25 years earlier than the general population. At Bridgeway, we were increasingly finding that physical health needs are just as prevalent and just as critical as mental health needs with the individuals we serve, especially in our supported housing residents. In response, we piloted a project to begin collecting, we call it the Thrive Project, and we began collecting A1C data from our supported housing tenants as well as our PACT residents. Because we are fortunate to have RNs and LPNs embedded in some of our supported housing teams, we're able to utilize our skills to assist the tenants with collecting this data. We also had some of the tenants supply us the information from if they had the MyChart set up, or we assisted them with transporting them to the labs to get the information. And on a quarterly basis, we had a laboratory come on site where we're able to bring our residents to the laboratory to get their A1C data. And what we found was concerning but not surprising that a significant number of our individuals were living with prediabetes, and some had diabetes that was completely untreated. And some people didn't even know that they were either at risk or had diabetes with their A1Cs. So in response, we partnered with Peggy Swarbrick, who's a national leader on the 8 dimensions of wellness. And through this collaboration, we provided extensive wellness training to our staff, both our supported housing staff and our PACT staff, as well as our outpatient staff, to develop, and we developed a wellness assessment to really look at those 8 dimensions, and then we created curriculum focusing on improving our individuals and the persons that we serve lifestyle and overall health. And those curriculums our staff are able to go out and utilize directly with our persons served to write in the areas that they need the most help. We also hired a nutritionist as part of this project, who provided staff training and also facilitates weekly groups directly with our individuals who want to work on improving their A1C and overall nutrition. It was also helpful for our staff to learn about the nutrition aspects. We developed a nutrition assessment to identify areas where our individuals can improve with their eating habits. In addition, we also have a medical advanced practice nurse who provides ongoing guidance and education to our staff. While we don't have a lot of data at this point, we are seeing trends of individuals lowering their A1Cs, reducing their weight, but most of all, increasing their overall awareness about better health and better healthy habits. This integrated approach highlights a major trend we are seeing in supported housing, the growing intersection of physical health and mental health care. From an advocacy perspective, I think it's important to emphasize that all these supports begin with one essential foundation: permanent supported housing. Permanent supported housing is an evidence-based practice, as Tina was talking about before, for individuals with disabilities, and it's critical for long-term stability and recovery. However, in New Jersey, there's an increasing development of luxury apartments that has pushed affordable housing further out of reach for the individuals that we serve. The average rent in New Jersey is now approximately $2,100 per month, in comparison to the average Social Security disability payment, which is $1,600 a month, and SSI, which supplemental Social Security income, which averages $967. In Union County, the HUD fair market rent for a housing voucher is $1,800, which often still falls short of the actual market rents. At a federal level, proposed reductions and restrictions to the continuum of care funding, which is funding for permanent supported housing, pose a serious threat to our ability to help individuals secure and maintain housing. According to the National Alliance to End Homelessness, recent proposals would shift funding away from Housing First and permanent supported housing towards transitional housing models. In New Jersey, state monitoring reports indicate that this shift could result as many as 2,000 individuals becoming homeless next year alone. At the same time, New Jersey has begun reducing funding for supportive services within supported housing, including reductions to the Department of Community Affairs funding for housing vouchers. These funding streams are all essential in providing flexible person-centered supports, integrated care, and will be our biggest advocacy needs in this coming year.
Great. And if you don't know it, as Peggy Swarbrick, created the 8 dimensions of wellness. If you just Google it, I was trying to sort of paste one of her many research papers. SAMHSA actually adapted it and adopted it at a federal level, and it is an evidence-based program and very successful. So thank you, Nancy, for sharing that and for the success you've had with it. Moving on, so Nicole and Christine, again, you have both focused sort of on different aspects of behavioral health at the community level, slightly different populations, and I would say people with more general behavioral health challenges, or people will have behavioral health challenges and intellectual disabilities with co-occurring behavioral health challenges again. So you talk about sort of your approaches, and what approaches you think are needed to ensure that individuals can be successful in the community, even if they've experienced an inpatient hospital placement. And maybe, Nicole, we can start out with you.
Sure. So we have to continue to, partner with local and state government to change policy and to get funds where they're needed. Some of the same things that Nancy just spoke about. We need to also partner with the patient, right, to identify what their goals are about what their life is going to look like in the community post-discharge, and ensure that we have shared decision making with them to achieve them. We can think of anything that we think is perfect for a patient, but if it's not something they prescribe to, then it won't work. We need to enlist family, friends, other caregivers, anyone that the patient identifies as a support for them to help the patient, on their journey. And Nancy also touched on integrative care. So it's essential. For some of our patients, admission to our hospital is the first time that they have seen a medical provider in a very long time. We try to take care of their dental needs, their nutritional needs. Sometimes we're the first person to tell them their blood pressure is high, trying to make sure that they leave on medical medications as well as whatever they need for psychiatrically. And then trying to get them follow-up for their chronic medical concerns post-discharge is equally important. We want to collaborate with community partners for their ongoing psychiatric care, including a warm handoff if we can before discharge, to make sure that patient has a familiarity with where they're going next and maybe are less afraid to go. Pharmacology education, medication management, safety plans, completed by the patient before discharge, whether it's a RAP plan or a Stanley Brown, to help with skill building. What do I do if I'm in a crisis again? We need to address their social determinants of health, which is also something Nancy talked about, because we know that those have a lasting impact on a person's mental health and well-being. And lastly, we need to reduce the stigma that individuals have so that they feel safe to get the care that they need. We need to treat mental health and substance use disorder the same way we treat cardiovascular health. And we cannot do that if, as a society, we stay judgmental and look at it as some sort of a moral failing, because it's not.
That's good. Christine, you want to sort of approach it from more the neurodiverse perspective?
Okay, as an agency, we take psychiatric and medical crisis very seriously, with the overarching goal of supporting individuals to live successfully in the community and avoiding unnecessary or prolonged hospitalizations. When an individual is admitted to the hospital, we immediately begin a coordinated review to understand what actually happened, what contributed to this individual's crisis, and to identify the supports needed to promote a safe and stable return to the community. Throughout the hospitalization, we maintain ongoing communication with the hospital treatment team to maintain the individual's clinical presentation, response to interventions, and any changes in treatment or medication. This process is highly collaborative and includes key members of the individual support network, such as nurses, residential leadership, behavioral support coordinators, and the guardian. These partners provide essential insight into the individual's baseline functioning and help inform discharge planning. In parallel, we assess whether the individual's current living environment continues to meet their needs, considering factors such as staffing supports, interpersonal dynamics, and the physical environment. When necessary, adjustments are made to better align supports with individuals' clinical and functional needs, always with focus on long-term stability and quality of life. We also work closely with external partners, including the division, clinical team, and support coordinators, organizations to increase supports and identify community-based resources that may be needed following discharge. When clinically indicated, short-term aftercare services such as CARES or crisis assessment, response, and enhancement services are incorporated to provide additional oversight, staff guidance, and support during the transition back to the community. Prior to discharge, a final coordination meeting is held to ensure alignment across all providers, particularly around the medication management and the individual's current clinical status. Following discharge, follow-up and monitoring are tailored to the individual's needs and history, with more frequent check-ins initially that are tapered as stability is achieved. This structured multidisciplinary approach allows us to respond act proactively to crisis, reduce the risk of rehospitalization, and support individuals in returning to the community with appropriate safeguards and supports in place.
Thanks, Christine. And I want to move a little bit on to the part of the paper which has much more to do with the systems, policy and systems change, and move on to a different set of questions. So looking at I would say regional, local, as I think John pointed out, state and also national levels. Let's sort of turn to our policy experts on the panel. And John, I'm going to put you on the policy side because and government side because you've been advising a lot of people over the years, and the same with Pookie. So you both have sort of different perspectives and experiences in terms of policy and systems change, but I know that drives both of you. And if so, Pookie, you mention it. So could you both speak a little bit about how you work in this arena and maybe some thoughts for the folks that are listening? And so maybe, John, you could start with you. You work in systems change, have always done that. You did at state level, nationally, human service sector. Now you're at the provider level, but I know you're a systems person at heart.
Yep. And maybe there's a reason why I'm back local, because looking at the state, and trying to influence federal policy, even it's challenging. And I appreciate, Pookie, you mentioned earlier the idea of macro change and policy change. And I found when I was doing that work at the state, and certainly we did develop policies that were statewide, but Pennsylvania, for people that don't know it, their child welfare system is a county administered system. So even as I was developing macro or state level policies, it was still, how do we implement this in 67 different counties? How do we build something that works for Philadelphia or Pittsburgh and also works for smaller counties with 8,000 people or 10,000 people? And being honest with you, I began to shift my thinking a little bit around some of the macro level, one size fits all, this is what we need to do, and how do we create, how do we change laws, how do we create policy, to how do I empower local organizations and local agencies who know their community, and I give them the resources within an overall structure. And I began to do more work around creating policies and practices from the state level that empowered the local communities. I created a housing, we've talked a bit about housing, so I was able to, going through a state budget, actually get some funding that allowed counties to use like unrestricted fundings to fill the gaps of people, to keep kids out of foster care. I was the Deputy Secretary for Children, Youth, and Families, so it was specific to kids in foster care, but how do you use unrestricted money? And it could be for different things, and it would be different, again, solutions in rural counties versus urban counties. And so I began to shift my policy thinking around how do I empower more local communities while maintaining some of this macro level thinking. And so it really was micro, macro, zooming in and zooming out for me while I was doing it. And that sort of began shifting. When I went to the state, I'm thinking, yes, we're going to do big things, and but the bureaucracy is hard. But I'll let Pookie talk more about that and how do you influence policy and legislation. But for me, it was really how do I begin to my thinking shifted to how do I empower locally. And then when I finished my work in the state, and I was doing consulting work, and I was doing consulting work at the national level, again thinking about it, we began to design some forums and some meetings, and actually had pulled a group of states together to talk about how do they look, and this was also specifically around child welfare, but how do they look at policy, how do they look at finance, how do they look at governance, how do they look at their service array from one perspective, and how do they pull their different pieces together. And we were working with multiple states around the country. How do you use your Medicaid dollars, and how do you look at financing and service array and behavioral health around child welfare systems collaboratively? And so I think Nicole mentioned partnerships earlier. A lot of our speakers have talked about partnerships. And again, I'll joke a little bit and say maybe there's a reason why I didn't go from state to federal. I came back to local because I do think, as I'd say, those closest to the problems are closest to the solutions. And I have found for myself being able to have this local impact. But we do have to understand the macro. We do have to understand the environment that we're living in, the context, the regulations, and the resources. We're really only going to be successful at the local level if we work collaboratively at the state and federal level and can sort of see the multiple levels working together in partnership.
And Pendel's lucky to have you, because I'm thinking with your experience, and now you're at the provider level. And I would say for somebody who's been doing a lot of policy and advocacy over the years, there's nothing more sort of powerful at the local level also to push in a leadership position with your team. Nick and I teach some courses at Penn and other places where we really talk about what makes strong leadership at the community level is advocacy, education. And you said it, we see firsthand the issues, and it's kind of on us to educate our policymakers, if not push, to make change happen that's right for the population we serve.
And I apologize. I think it was Nicole who talked about the people have to have a voice, and so it's really elevating the voice of the community to influence policy, and looking at it from that lens.
Well, we look forward to working some stuff with you locally, so I'm glad to have you here. Well, Pokey, you have sort of the different sort of perspective, so why don't I turn over to you?
Sure. And John, I really have to say, I like what you said, and definitely bringing the macro and micro together. I think for me too, as I was listening to you speak, and as you brought up advocacy, that's definitely what started to resonate, where it was giving voices, or giving a voice sometimes to those who may not always be heard. And I think Hawaii is unique in some ways, and probably very similar to other ways, but that integration of maybe downstream, but then going upstream of being part of a culture and a people and a community in a place that gets isolated, and feeling that your voice isn't heard, not just as singular, but as a community in general. And so I love the way that you threaded that together, because I think for many of us, I can't speak for everybody in Hawaii, but for myself and many of us in the communities, I think we start at that micro level, and then we work our ways up because we're living it. We know what needs to be done, what's going to work, what can work, but we also need to collaborate and come together with other perspectives in other areas. So I just want to say I appreciate how you pulled that all together. Team, to your question from, I guess, other perspectives, some of the most important lessons, I think, in policy between aging, disability, and behavioral health, caregiving, is that it cannot live in separate lanes anymore. The populations we serve overlap, and our systems really need to reflect that reality. And as we're looking at our systems, for instance, we still pay for individual services, or fee for services, or we pay for our doctor's visits, instead of supporting the outcome that we actually need, like housing or food, staying healthy, having family support. So it's still a fragmented and siloed system. And that disconnects makes it so much harder, right, rather than easier for us to come together. When I'm having patients and they're not showing up for appointments, my question is why? Not if they don't show up for 3 times, we put them on the list and aren't going to provide care for them. I want to know why. Is it because the bus stop is 3 miles away? Is it because they're more worried about where they're going to eat tomorrow than trying to come and see me? And so just this, trying to really reach people at where they are. So moving forward, I just think it's more intentionally and aligning federal state policy so that innovation, isn't penalized. That innovation is really supported. That includes, things like the Medicaid waiver, stronger support for home and community-based services, and policies that recognize the essential role of family caregivers and the direct care workforce. So another critical issue is our workforce sustainability. So without addressing wages, training, career pathways, even the best policy ideas won't translate into real access. So systems change has to account for the people delivering the care, not just those receiving it, but system change really, right? We need to look at the entire system and everybody involved in it and create something that's going to benefit all of us.
I think it's a great point. And actually, Steve, so let me just jump into Steve's question, because I sort of maybe building a little bit more what you were saying, Pokey, for you, and maybe for everybody, we can all comment on it. He's asking sort of how do we shift the human service delivery system from more bureaucracy, and I would say, I think it's health and human services, and I think you all said it. It's all the silos. We tend to put government in silos, and then we move we departments around, but it doesn't get to the what, and you mentioned really value-based care and looking at the bigger picture. How do we shift that? What do we need to do? There's a lot of, I'm looking at who's listening in. A lot of really amazing folks that are that are running organizations, that are running programs, services, etc. What can we do? Because I think a lot of this can come from the community, can come from us. So what are some of the things you might, recommend to us to push that change? Maybe John, Pokey, or anybody else?
Yeah, well, I mean, one thing I'll say, since I've been here, and is I've said to my staff a lot, like, we want to build programs for people, not fit people into our programs. And I think we have a lot of pre-existing programs already that maybe they have needs. Should we put them in this one or that one? But there's not really one built for them particularly. And so I do think, the phrase, right, culture eats strategy for breakfast. I think like our culture has to be, how do we really get individualized needs met? How are we responsive? If our programs are doing the same things they were doing 10 years ago, then they're probably not doing the things people need today. And just being adaptive and responsive and open to how do we shift and change and adapt, and not just keep doing things the way we've always done them because it's the way we've always done them. And it sounds obvious. I think everybody would say that sounds right, but it's hard to do in the environment, right? It's hard to really change, when budgets are made well in advance, and it's hard to find staff and all that. I think we have to acknowledge it's hard, but I think we're all doing this work, even though it's hard, because we care. I'd say that about everybody on the panel, and I'm sure everybody else who's joined, but it's hard work, but we have to shift our culture and our thinking along with some of the tactical pieces of it.
And I think that goes with a little bit, I think the certified community mental health centers are a good example where you're bringing other things together, including social services. There are programs. I don't think there's enough of them. I think the PACE model, which is more for elderly, that some of us are hoping we can adapt for more of a neurodivergent populations, where you'll provide an all-inclusive care, really a managed care provider-led model for people with, elderly people that are dual eligible, Medicaid and Medicare, very vulnerable. There are frameworks, I think, at the federal level that could come down to the state level. If they already are at the state level, then we might be able to adapt to. So I think it's there, but it's using it and pushing it.
But it's been mentioned, sort of the holistic. Also, I think it was mentioned earlier, like the lack of transportation could waylay a whole. You could have this perfect program for the person, but if they can't get there, if they don't have the access, the access is so important.
Which is why, so these more inclusive programs, make sense. So good. And I think, some of the, one of the comments from Kimberly is that she thinks most treatment fields have already shifted to person-centered care, but without that financial support for addressing all the other areas you just mentioned, the silos could continue. And I think that's something in the advocacy community we tend to advocate for. Just a sector. This is across, and I think something for us to think about more, and maybe at the community levels coming together.
I think I
Go ahead.
think,
Go ahead, Chris.
yeah, I think that, something like continuing conversation, and meeting up like this. A lot of times, when we do come together, we create new ideas and create things. So I thoroughly enjoy these conversations because it gets my brain thinking. And then I think sometimes when we leave from these panels or these conferences, we go back into our own worlds and begin working again, forgetting that we have a network of people. I don't have to do everything because I have Woods and I have Pendel and so we can do more together than we can do separately.
Well said. Nancy's asking the question, what are your thoughts and the panel's thoughts about how equipped are providers to serve people with complex conditions, and is there a way to improve training for providers in general? I said at the Woods system, we do it as the Molly Voltaire, global center, we do it also globally. Just curious what's going on in the organizations, and any thoughts from our speakers?
I think you just have to make a commitment and invest in the training, right? Put it in your budget and commit to doing it. So trauma informed care is a great example. We have trained every single person in this 100-bed facility, inclusive of our housekeepers and dietary teams, on what it is to be trauma informed, right? Because it's not only helpful for our patients and here, but our team can take it to their regular home life as well. And now we're spreading that across the service line, right? Adding it to budgets for 26 and putting this training in the hands of the people who can do good work with it.
Sounds great. Yeah, I think that's a great point. Any others want to weigh in?
I mean, I will say, I think we are definitely have seen a shift. I mean, we are definitely better positioned than we were 10 years ago or what have you, and that these conversations do happen. I think the point I was trying to make earlier is that it's hard. And also, I think, Christine, as you were saying, like, it can't just be the conversations have to continue and it has to turn into actions. And Nicole, the point about training staff, new staff have to come in and they have to not just learn their job, but they have to learn these other components to it and really have to be taught to think in an integrated manner. And then even as we train them and do performance management and what have you, I think we have to reward them when they are collaborative, right? When they are integrated.
You touched on it before when you said culture eats strategy, right? It is all about the culture, right? A warm environment to learn and grow in versus an authoritarian one where, you're just going to do your job, you punch in and you punch out.
That's a great point. So, Liz is asking, she's wondering what are you seeing in terms of trends and services for people with dual diagnosis of intellectual disability and mental health challenges, if any? Are there any new types of programs you've seen? And I know, John, you have just recently been at another agency that certainly has their fingers on the pulse of a lot of things going on. Just curious, but anybody on the panel, have you seen any sort of innovative programs? Other than the ones you all wrote about, of course. So,
well, I do think that's a topic, an area of growth. I mean, I think
Yeah.
with autism and ID, and I think that we need to, as a human services system, think more about it. I think we have a lot of folks who maybe had been living with their parents, and their parents are getting older, and the housing for that population, I think, is things that we have to think about systemically as well. And then again, I know there was a few articles about housing. I think housing is a really important part of this conversation as we're talking about the folks that we're serving.
And I think that's a great point. My vantage point, my first job was working in a housing authority in Philadelphia, and that's how I actually entered healthcare, because we worked with the federal government and brought HUD, U.S. Department of Housing and Urban Development, and U.S. Department of Health and Human Services together to really realize that healthcare and housing was connected. This is, I'm not going to say my age, but a long time ago. And we were actually able to start, sort of the FQHC program in a federal qualified health centers using, the approach of really. Now today there are, housing and public housing and health centers in many parts of the country. So the connection of the two, the power of having a place to be and a home, it's critical to do a lot of the service. So I think it's a great point, Joanne. So let's go to so I want to make sure we don't run out of time. So the final question for our panelists is that so just love for each of you to share some thoughts about what we need to be, how we need to be, or what we need to be actively planning to ensure that the populations we serve continue to have access to much needed services. I think we all know change is coming. And I think we're all thinking about what we need to do in our respective organizations and communities. But how can we continue to innovate as we design new ways to approach persisting problems, and perhaps with a little bit of wind or headwind against us, given sort of the financial environment. So maybe start with you, Pookie, and you're in the heart of it at the national level.
Sure, thank you. This question, I really appreciated when you posed it to us. So I think right now it's just it's a different time. It's a new time. And so it's a time to really be intentional about planning for uncertainty. Policy environments are shifting like they always do. Funding priorities are changing as we're all feeling and seeing, and that instability disproportionately affects people with complex needs. So if I can lay out just 3 points. So first, needing to protect access, right? Especially things like our Medicaid funded services that really support the individuals with disabilities, the older adults, the people with behavioral health needs. These services are all often the first to feel pressure during fiscal tightening, and even though they are foundational to keeping people supported in their homes and communities. Secondly, we need to continue investing in models that work across sectors and bring fragmented systems together. As many of us have already mentioned, the housing, the healthcare, the behavioral health, the services, instead of operating in silos, coordinating and coming together. Ensure that supports are following people into the community rather than stopping at discharge, for example, and help to close the gaps. Innovation, doesn't always require creating something new. I think, Teen, you mentioned that earlier. Sometimes it's really about removing barriers that prevent the systems from working together. Third, keeping families and individuals and caregivers and direct care workforce at the center of planning. Lived experience should really inform policy, support flexibility, financial sustainability, and really going back to lived experience, it really shouldn't be an afterthought. The perspectives to help ensure that systems are resilient, equitable, and responsive, and policies that recognize this are essential. So ultimately, sustaining progress will require collaboration, which we have talked about endlessly in this conversation across federal, state, and community levels, and a willingness to design policies that reflect the real complexity of the people's lives. And saying that, I just want to note to some of the two questions I think they had posed earlier. As we talk about reflecting the real complexity of people's lives, or reflecting or creating things that are actually going to affect people in their homes. One program, as we were talking about training, I think, training and issues like this, understanding these conversations really should start before the workplace, starting, whether it's in the training and the schools and the education when everybody is, going to college, or before that, having conversations in our communities and together, making sure that the people that we are serving are part of the panels we're putting together, the advisory councils are part of the training. There is a program that it's pretty much everywhere, but those with disabilities, work with the clinicians and all the therapists, and they are part of the IDD team, and they go with them, and that is to help them to understand, right, how to address the needs, how to support them. And so those type of issues, I think, and programs are very much needed. And that, I thought, just was a wonderful program that I got to be a part of, and to see it. It definitely helped me. And I've also been on the other side where I've been able to, share with people what it really is like to be a caregiver. And to our point about bureaucracy, I don't think we're ever going to have no bureaucracy, but we can change the way that it is, its prioritization, what it came from, how it was, and really take a look at it and how to build it now into something that can really support all of us and what we need.
Oh, great comments. So, John, go to you next.
Yeah, those were great comments. I don't know that I could approve on any of it, but I will say, I mean, I had also thought about that concept that you just mentioned around policy that reduces barriers, not creating barriers to access, and really thinking about that. Thinking about that university level of the community, and how are they training like the next generation of leaders and caregivers and healthcare. And then I'm thinking also about the partners that I don't know if they're on this call or not, but we think about human services, we think about government, we think about public-private partnerships. We have to pull in schools, right? We have to pull in hospitals and physical healthcare. I think that was mentioned earlier a little bit. But thinking broadly, thinking about the community action agencies that serve the poverty, try to improve on poverty conditions in our communities, and how do we sort of maybe broaden our partnerships and recognize that the people who are receiving human services are also doing other things in their lives, like sending their kids to school or going to hospitals or being a part of other communities and faith related systems and what have you. So maybe broadening our thinking even again about who the partners are in the community and who the people that we work with interact in their day-to-day lives. And the challenges, if we're having challenges with resources, that was the beginning of this question from the federal level. Sometimes the crisis creates opportunity, right? And so maybe it's the opportunity of rethinking and saying, what do we need to do around these partnerships, and how do we remove barriers versus creating additional barriers? So.
No, great points. Thank you, Sean. Christine?
All right, so agencies must plan strategically to ensure continued services for this population, especially given the financial challenges anticipated under the current administration. The passage of the Big Beautiful Bill signals an estimated $990 billion reduction in federal spending over the next 10 years, which will likely impact funding for critical services. In this environment, agencies that develop strong fiscal responsibility, an agency able to provide a well-integrated service delivery model that's cost-effective will be best positioned to sustain funding. Additionally, the passage of the Heads Up Act, I really pray that goes through, would be a significant benefit as it would provide incentive for providers to extend and specialize in medical as well as dental services for our individuals. And, as I thought about this question also, I thought about and this I'm going to swing it in, but Lilly Ledbetter, how she was determined, she was consistent, she was persistent that women's wages should be equal to men. And I feel like we need to stay the course. She went to, when those who wouldn't hear her in her local area, she went to Washington and she knocked on doors and she stayed in their faces and she stayed in their ear. I mean, she pushed it until she went to the Supreme Court. I really think that our individuals matter. The services that we provide matter. And so I feel like we need to just stay consistent with our what we are fighting for, and let the legislators know we're not going anywhere. We need this money for services. Our individuals can do more than just be home. They are citizens that should be a part of society just like anyone else. And so we need these fundings to support them.
I like the word stay the course, Christine. That's a great message.
Yes.
Nicole?
Yeah, so many great responses already, and not really much to add. Just to say, talk to the people who are directly affected, right? Hear from them.
That's a great point. Did we lose Nicole?
Community level, and respite care. Give families an alternative to the emergency room. Build flexibility in our processes so that individuals can access, needs or access programs that are, not necessarily niche to them. Share in conversations just like this, what's working well, and then steal ideas, and don't be ashamed of that.
I like that, Nicole. And one of the things, we're working with you on, and your system is this whole transitions in care, right? I mean, the step down, etc. There are some easy gaps that is beneficial to everybody. Respite, you mentioned respite, but there's also the step down into the, for example, if somebody been inpatient into the community, but you might not be ready to go quite home, but there are levels of care that we can, step people down to, and it's hard. Doesn't really exist now. That might
does
be
not.
right. And an easy fix for us and suggest just in one little area, in which it costs.
Yeah, I don't think people realize how restrictive inpatient psychiatric care really is, and the infringement on your rights as a person. And if you don't need to be here clinically anymore, we need to get you out. It's the right thing to do. But finding that place when you can't necessarily go home is definitely a challenge.
Great point. All right, Nancy, last but not least.
Hey, save the best for last, right? I think these were all good points. Pokey and John talked about it on the federal level in supported housing. There's three core pillars, right? So there's access to affordable housing, sufficient service operating dollars, and providing the flexible individualized support. And they're all at risk at this point. So working with our state and local advocacy groups on advocating for these services is really important. And Christine and Nicole talked more about individuals and the families. I mean, this is why we're working in this program, is to really help those individuals and families get the services and supports that they need. And just paying attention to the integrated care piece. I was thinking about Liz's question about providing services to those with dual disorders as well as IDD services. And we do have individuals in our supported housing programs that meet all those criteria, and partnerships is a big part of it. What makes it work, it's not regulations, it's not funding, it's just working closely with our partners to help those individuals in any way we can, and really providing those services on a one-on individual basis and not thinking of them as a system, right? And then lastly, just working forward-looking, integrated and advocacy-driven care is what we need to do, and sustaining advocacy at every level.
Great points. And I seek some collaboration suggestions in the chat box. I love that. And I also, just to be remiss to say that Nikolai posted if you want to access to the journal in the chat, and there was also some other sort of resources in the chat box. So hopefully you capture them. With that, I want to give our amazing panel a round of applause. What a great conversation, and again, what a great addition. And then I want to turn it over to Nick to close us out. And Nick, there's lots of other things going on with the journal, including New Jersey and the Pennsylvania Regional Award. So why don't you take it away?
Sorry, I was on mute. Thanks, Teen. I just want to say that the journal has also been on this mission to find change makers and nonprofits who are doing amazing work in their communities. And so the Greater Philadelphia Awards have already kicked off. All the nominations have already been received. We've received over about 200 nominations in about 12 categories, from systems and strategy, social mobility, human services, health and living, and community champions. And those are the best thing about this is of those 200 nominations, we'll narrow them down to about six finalists per category, representing the 5 counties. And then we'll shoot it back out to you for the public voting. This is a way to most educate you about the amazing work that's going on in the communities or in our backyards. But then our secondary vision is we want to drive capital into these and really put more dollars into them. And thanks to the Tabor Services Foundation, as well as the Patricia Kind Family Foundation, last year we were able to drive about $100,000 to these change makers within the group. So now these awards are not only about recognition, but about driving them. And I'll turn it over to my colleague Nikolai to give you the highlights of the New Jersey Awards, which don't kick off until the January. So Nikolai.
Yes, I'm happy to report that we will be doing the New Jersey Social Innovation Awards next year. It will be at the amazing Connor Strong Buccaloo campus as we were the previous years. We've just started the phase of getting new people registered and interested in getting the awards kicked off, and we'll in the new year have more information on the awards categories and nominations. But I put the links into the chat for the website for both Philadelphia and New Jersey. And if you are from New Jersey and you think you could think of some great organizations and individuals you'd love to nominate, please do fill out that form. And when the time comes, we will reach out to you to fill out that survey. But thank you so much.
Great. And with that, I just want to say thank everybody for staying with us. Wonderful conversation, and stay tuned for future social innovations conversations. So thank you, and have a wonderful holiday season, everyone.
Thank you.
Take care.